Dear audience, Assalamu alaikum. I am Professor Shamsudjaman, Professor of Pathology. I welcome all in today's 7th lecture on Hematology. Today, day 2 of lecture on leukemia. Now come to leukemia. Today, first come to acute lymphoblastic leukemia, then acute myeloblastic leukemia. First come to acute lymphoblastic leukemia, after then acute myeloblastic leukemia. If anybody suffers from acute lymphoblastic leukemia, you know it is a acute disease and it is blood cancer. If anybody suffers from acute lymphoblastic leukemia, what may be the clinical presentations? First come to clinical presentations of acute lymphoblastic leukemia. Clinical presentations. Age of occurrence, you know acute lymphoblastic leukemia, it occurs in childhood. Usually it occurs under the age of 5 years. Usually under 5 years of age. Then symptoms of anemia. Symptoms of anemia like fatigue, effort intolerance, then palpitation, pallor. So these are the symptoms of anemia. First one is age of occurrence, then symptoms of anemia, then frequent fever. The patient will come to you with frequent fever, then hemorrhagic manifestations. These are the common symptoms or clinical presentations of anemia. In addition to this, there may be lymphadenopathy, there may be mouth and pharyngeal infection, and patient may develop gum hypertrophy also, and sometimes patient may come to you with bone pain, usually in childhood, So these are the clinical presentations of acute leukemia. Now come to, if this is the medullary cavity containing bone marrow and this is the cortex of bone. Leukemia is the blood cancer of hematopoietic stem cell. If leukemia occurs in the bone marrow is packed up with leukemic cell. Bone marrow will be packed up with leukemic cell, and the bone marrow is packed up with leukemic cell. The erythroid series is compressed, and so there is inadequate formation of RBC. Due to inadequate formation of RBC, there will be symptoms of anemia, that is anemia. Again, as the bone marrow is packed up with leukemic cell, and you know leukemic cells are the WBC series here, and most of the cells are the immature cell. As the immature WBC is not well functioning, so it cannot give protection, so there is frequent infection, and due to frequent infection there will be frequent fever. Again, as the bone marrow is packed up with the leukemic cell, The megakaryocyte from which the platelet is formed, platelet is formed, the megakaryocyte is depressed or decreased in number. So, there is decreased number of platelet formation. So, there is thrombocytopenia, and due to thrombocytopenia there is bleeding manifestations like gum bleeding, nasal bleeding, then there is purpuric spot. So, these are the different clinical presentations of acute lymphoblastic leukemia. Now come to if anybody suffers from acute lymphoblastic leukemia and if you clinically suspect it could be case of acute lymphoblastic leukemia, how the acute lymphoblastic leukemia can be diagnosed in laboratory. Now come to laboratory diagnosis of acute lymphoblastic leukemia. Diagnosis of acute lymphoblastic leukemia. We have to do blood examination, then bone marrow examination, then we have to do myeloperoxidase test, then we have to do chromosomal study, we have to do cytochemistry, and we have to do flow cytometry. Now come to blood examination to diagnose acute lymphoblastic leukemia. Now come to blood examination. First we have to do hemoglobin. Estimation. As the patient is anemic, it will be decreased. Then we have to do ESR, erythrocyte sedimentation rate. It will be elevated. Then total leukocyte count. It will be leukocytosis. Dear audience, you know the normal total count of WBC is 4,000 to 11,000 per cubic millimeter of blood. It will be increased. It is called leukocytosis, and the total count of WBC may exceed 1 lakh per cubic millimeter of blood. It may exceed 1 lakh per cubic millimeter of blood. So it may exceed 1 lakh per cubic millimeter of blood. Then we have to do differential leukocyte count, DLC. If we do DLC, we will get most of the cells are blast and atypical. Most of the cells are lymphoblast, and often neutropenia. So we'll get most of the cells are lymphoblast, and it is associated with neutropenia. Then we have to do peripheral blood film, PBF. Dear audience, you know in PBF we search for RBC series, WBC series and platelet. Now come to first RBC series. The cells of RBC series show anisocytosis with a few nucleated red cells. Cells of RBC series show anisocytosis with a few nucleated red cells. Then WBC series, the cells of WBC series show leukocytosis, with most of the cells are lymphoblast. Show leukocytosis with most of the cells are lymphoblast. Dear audience, you know lymphoblast is a blast cell. It has got round nucleus. It has got round nucleus like this. It has got a round nucleus. There is no cytoplasmic granules, and there is 1 to 2 nucleoli. So this is the lymphoblast. Then platelet seen reduced. So in the peripheral blood film, we show anisocytosis with a few nuclear red cell in RBC series. In WBC series, we will get leukocytosis, and most of the cells are lymphoblast, and platelet seen reduced. So this is the peripheral blood film findings of acute lymphoblastic leukemia. Now come to reticulocyte count. Dear audience, you know normal reticulocyte count is 0 to 2%. Here it will be increased. Now come to if again it is bone marrow. This is the cortex, and medullary contents, this is the bone marrow, and this is packed up with the leukemic cells. So RBC series is depressed here, so inadequate number of RBC is formed. So there is anemia, and due to anemia, the bone marrow is stimulated to produce RBC rapidly. Due to rapid production of RBC, some nucleated red cell comes in the peripheral blood. Again, due to rapid production of RBC, before maturation, some reticulocyte comes in peripheral blood. So when we get increased number of reticulocyte in peripheral blood in acute lymphoblastic leukemia. Now come to bone marrow examination. Dear audience, in bone marrow we see the cellularity, myeloid erythroid ratio, erythropoiesis, granulopoiesis, megakaryocytes, etc. Now come to bone marrow of acute lymphoblastic leukemia. One thing is important, we know in our blood all RBC comes from the bone marrow, all granulocytes come from the bone marrow, but the maximum or most of the number of circulating lymphocyte, either small lymphocyte or lymphocyte, comes from the lymphoid tissue. Very few number of lymphocytes circulating in the blood comes from the bone marrow. So from the bone marrow, very negligible number of lymphocyte comes from the bone marrow in the peripheral blood. So the normal bone marrow, the number or the number of lymphocyte series in bone marrow is very insignificant, insignificant number. So in bone marrow, in case of acute lymphoblastic leukemia, what it will show? First, cellularity. Marrow is hypercellular. As it is a cancer of bone marrow, it is a cancer of hemopoietic stem cell, so increased number of cells in the bone marrow, so marrow is hypercellular. As the hypercellularity is due to lymphoid series, so here erythroid series is depressed, rather the myeloid series will be increased. So marrow is hypercellular with increased myeloid erythroid ratio. So marrow is hypercellular with increased myeloid erythroid ratio. Why myeloid is increased? Because it is not a cancer of RBC series. Then erythropoiesis. Erythropoiesis is depressed but normoblastic. Dear audience, as it is a disease other than the RBC series in the bone marrow, so erythropoiesis is depressed but it is normoblastic. Then granulopoiesis is depressed. Granulopoiesis is depressed. Why depressed? Normal bone marrow contains very negligible number of lymphoid series cell. As it is a case of acute lymphoblastic leukemia, so lymphoid series cell is increased in the bone marrow, so there is depression of the granulopoiesis. So granulopoiesis is depressed, and major portion of marrow is replaced by lymphoblast or immature cells of lymphoid series. Dear audience, again I want to say, in normal bone marrow, lymphopoiesis is very negligible, but granulopoiesis is more than the lymphopoiesis. As it is case of acute lymphoblastic leukemia, lymphopoiesis is increased, lymphoid size of series is increased in the marrow, so granulopoiesis is depressed. As the granulopoiesis is depressed, the major portion in the bone marrow is replaced by immature cells, that is a lymphoblast of lymphoid series. Then megakaryocyte seen reduced, and megakaryocyte seen reduced, no parasite found. In the marrow examined. No parasite found in the marrow examined. Again I want to recall, marrow is hypercellular, as it is cancer of hemolytic stem cell, so marrow is hypercellular with increased myeloid erythroid ratio. As the myeloid series is increased due to lymphoid series cancer, so myeloid erythroid ratio is increased. As it is a cancer of WBC series, so erythropoiesis is depressed but it is normoblastic. As it is a cancer of lymphoid series, so granulopoiesis is depressed and major portion of marrow is replaced by immature lymphoid series of cells, that is replaced by lymphoblast, and megakaryocyte seen reduced, no parasite found in the marrow examined. This is all about the bone marrow findings of acute lymphoblastic leukemia. Now come to myeloperoxidase test. Myeloperoxidase test. Dear audience, you know myeloblast is peroxidase positive and lymphoblast is peroxidase negative. If we put myeloblast in peroxidase test, myeloblast is peroxidase positive and lymphoblast is peroxidase negative. So lymphoblast is peroxidase negative. It is negative. Then come to chromosomal study. This is nothing but karyotyping. Here we search for Philadelphia chromosome. Dear audience, what is Philadelphia chromosome? You know translocation. If you consider this is the ninth chromosome, and if it is the 22nd chromosome, that is 22nd chromosome. If a part of this short arm of 9th chromosome is exchanged with the same length of short arm of 22nd chromosome. If this red portion come here and black portion go there, this is called translocation. If there is translocation, after translocation what we will get? After translocation we will get the red portion is here and the black portion is here. This is called translocation. This is called translocation. This is translocation. So after translocation, after translocation, so after translocation, the 22nd chromosome, this chromosome is called Philadelphia chromosome. So after translocation between 9th and 22nd chromosome, this 22nd chromosome is called Philadelphia chromosome. It is called Philadelphia chromosome. Why it is called Philadelphia? It is called Philadelphia according to name of city Philadelphia. So Philadelphia, this Philadelphia chromosome, usually found in myeloblast, not in lymphoblast. So in lymphoblast we will not get Philadelphia chromosome. Then come to cytochemistry. Cytochemistry. Why we do cytochemistry? We do cytochemistry to differentiate the blast cells of different series of cells. So we do cytochemistry. Cytochemistry is done to differentiate blast cells of myeloid series, blast cells of lymphoid series, and blast cell of monocyte series. So by doing or by using cytochemistry, we can differentiate the blast cells of myeloid series, blast cell of lymphoid series, and blast cell of monocyte series. Dear audience, again I want to recall, in case of acute lymphoblastic leukemia in bone marrow and also in the peripheral blood, we will get most of the immune cells or most of the blast cells are the lymphoblast. So we have to differentiate lymphoblast in different ways. So by cytochemistry, we can differentiate the lymphoblast from other blast cells like myeloid series, like monocyte series by cytochemistry. Now come to flow cytometry. Flow cytometry, flow cytocell metry measurement. Flow cell metry, flow cytometry. Here what is done here? You know, if this is a cell membrane, and if this is nucleus, there is membrane. If this is chromosome within it, and the chromosome, you know, is composed of DNA. Chromosome is composed of DNA. What is done in flow cytometry? In flow cytometry, what is done? The membrane of cell membranes of cell, DNA of cell, these are strained. So in flow cytometry, the membranes of cell, the DNA of cell is strained. After straining, cells are allowed to pass as a lamellar flow. So after staining, the cells are allowed to pass as a lamellar flow. That is, one after one. Cell one after one is allowed to pass, all our cells. After staining, cells are allowed to pass as a lamellar flow through a laser beam. So after staining, the cells are allowed to pass as a lamellar flow through a laser beam. Then what happens? As the cells are flown as a lamellar flow, the stained cells through a laser beam. Then light scatter on the cell. Light scatter on the cell is measured. Light scattered on the cell is measured by fluorescence, impedance. As the light scatter is measured by fluorescent impedance, we can diagnose, we can identify the lymphoblast, we can identify the blast cells. This is flow cytometry. Dear audience, this is all about the laboratory diagnosis of acute lymphoblastic leukemia. Now come to acute myeloblastic leukemia. Now come to acute myeloblastic leukemia, AML. First come to the clinical presentation of acute myeloblastic leukemia. Clinical presentations. First come to clinical presentations. Dear audience, you know it is acute leukemia. It usually occurs in childhood, but commonly acute myeloblastic leukemia occurs after the age of 5 years. So age of occurrence usually after 5 years of age. Then there will be symptoms of anemia. Like before. Then there will be frequent infections. There is frequent fever due to frequent infections. Then there will be hemorrhagic manifestations. Dear audience, the symptoms of anemia, frequent fever, hemorrhagic manifestations, why these occurs in acute myeloblastic leukemia? Explanation like that of acute lymphoblastic leukemia. In addition, there may be splenomegaly, there may be hepatomegaly. So these are the clinical presentations of acute myeloblastic leukemia. Now come to, if anybody suffers from acute myeloblastic leukemia And if you suspect it could be case of acute myeloblastic leukemia clinically, then how laboratory can investigate that case. Now come to laboratory diagnosis of acute myeloblastic leukemia. Laboratory diagnosis of acute myeloblastic leukemia. Now come to laboratory diagnosis of acute myeloblastic leukemia. What you do here, like acute leukemia, first we have to do blood examination. Then bone marrow examination. Then myeloperoxidase test. Then we have to do chromosomal study. Then we have to do cytochemistry. Then we have to do flow cytometry. Students, we have to do blood examination, bone marrow examination, myeloperoxidase test, chromosomal study, cytochemistry, flow cytometry, like acute lymphoblastic leukemia. First come to blood examination. We have to do first hemoglobin estimation. As the patient is anemic, hemoglobin will be reduced. Then we have to do ESR, it will be elevated. We have to do TLC, total leukocyte count, there will be leukocytosis. And like acute lymphoblastic leukemia, the TLC may exceed 1 lakh per cubic millimeter of blood. May exceed 1 lakh per cubic millimeter of blood. Then we have to do DLC, differential leukocyte count. In differential leukocyte count, here we will get most of the cells are myeloblast, but in case of lymphoblastic leukemia, we got most of the cells are lymphoblast. So here most of the cells are myeloblast with often neutropenia. So if it is a myeloblast larger than lymphoblast, you know, and the myeloblast has indented nucleus, you know, it has got indented nucleus like this, and you know myeloblast sometimes contains granules or body here, and there is 2 to 5 nucleoli. So this is the myeloblast. Then we have to do peripheral blood film. Now come to peripheral blood film, PBF. Like before, we have to see or we have to search for RBC series, WBC series and platelet. First come to RBC series. Cells show anisocytosis. Anisocytosis with a few nucleated red cells. Why nucleated red cells in acute myeloblastic leukemia? The explanation that I have given in case of acute lymphoblastic leukemia, same explanation. WBC series, cells show leukocytosis with most of the cells are myeloblast. With most of the cells are myeloblast. Then platelet seen reduced in the field examined. Then reticulocyte count. It is increased. The explanation like increased reticulocyte count in acute lymphoblastic leukemia. Now come to bone marrow examination. Dear audience, acute myeloblastic leukemia is a blood cancer of granulocyte series. Here the granulopoiesis is affected, but in case of acute lymphoblastic leukemia, lymphopoiesis is affected. So marrow is hypercellular with increased myeloid erythroid ratio. So marrow is hypercellular with increased myeloid erythroid ratio. Why increased ratio? Because it is not a disease of RBC series, rather it is disease of granulocyte series. So granulopoiesis is hyperactive, so there will be increased myeloid erythroid ratio. Then erythropoiesis is depressed like before, but normoblastic. Granulopoiesis is hyperactive. Dear audience, as it is a cancer of granulocyte series, so granulopoiesis is hyperactive. But in case of acute lymphoblastic leukemia, as it is a cancer of lymphoid series, so lymphoid series is hyperactive, so there was granulopoiesis depressed. So granulopoiesis is hyperactive here, and most of the cells are myeloblast. Dear audience, previously I have told you to diagnose a case of leukemia either in bone marrow or in peripheral blood, we need more than 15% cells are blast, 15% cells are immature. So here most of the cells are myeloblast. Then megakaryocyte seen reduced, no parasite found. In the marrow examined. So this is the bone marrow examination. Marrow is hypercellular with increased myeloid erythroid ratio. Erythropoiesis is depressed but normoblastic. Granulopoiesis is hyperactive and most of the cells are myeloblast. Megakaryocyte seen reduced. No parasite found in the marrow examined. Then we have to do myeloperoxidase test. You know, myeloblast is peroxidase positive. Then we have to do chromosomal study. Chromosomal study for Philadelphia chromosome. If we do karyotyping to identify Philadelphia chromosome, again we recall after translocation between 9th and 22nd chromosome, the 22nd chromosome is called Philadelphia chromosome, and this Philadelphia chromosome usually found in myeloblast, usually found in myeloblast. Usually found in myeloblast. Then we have to do cytochemistry. Cytochemistry, we do cytochemistry here again to differentiate the blast cells of myeloid series, blast cell of monocyte series, and blast cell of lymphoid series. To differentiate blast cells of myeloid series, to differentiate blast cells of lymphoid series, and to differentiate blast cell of monocyte series. Lastly, we do flow cytometry. We have to do flow cytometry. And like before, the flow cytometry is done for acute lymphoblastic leukemia. This flow cytometry is done for acute myeloblastic leukemia. So this is all about the laboratory diagnosis of acute myeloblastic leukemia, and this is all about the today's lecture about acute lymphoblastic leukemia and acute myeloblastic leukemia. Dear audience, thanks all.